Welcome, everyone. I am Rachel, Community Manager here at Alloy Women's Health. We are a telehealth platform bringing science-backed, evidence-based menopause hormonal solutions direct to your door. Today, I invite you to enjoy $20 off any purchase on our website, myalloy.com, using the code MHT20. We are welcomed today by medical advisor, Dr. Corinne Menn. She is a board-certified OBGYN and Menopause Society certified practitioner. She's also a medical advisor and prescribing doctor here at Alloy. Dr. Menn is also a 23-year survivor of breast cancer and premature menopause, a BRCA carrier, and uses her experience to help women navigate their health challenges. She has dedicated her medical practice to menopause management, the unique healthcare needs of female cancer survivors and those at high risk for breast cancer. Now practicing exclusively through telehealth, Dr. Menn provides women's health consultations and patient education. She's an active member of the Menopause Society and a fellow of the American College of Obstetrics and Gynecology. She's a dedicated advocate and volunteer for the Young Survival Coalition, serving on their Council of Advisors, leading the Provider Survivor Support Group, and serving on the Breast Cancer Alliance Research Grant Committee. Dr. Menn is a frequent speaker and podcast guest and has an active social media platform where she reigns, for sure. She shares her message there and her mission of educating fellow clinicians and women on menopause and women's health. Thank you for being here, Dr. Menn. We are a long time coming and having our own discussion for women on MHT, menopause, perimenopause, and all things related. Let's start, if you would, by sort of putting guardrails around this conversation, by, if you would, identifying who we are at Alloy, what we do, what we provide. Let's get us started there.
Great. Well, thank you so much for having me. And I think we have a lot of, kind of common interest and mission, and that you and I both connect a lot because we love just giving women access to education. Because as our chief medical advisor, Dr. Sharon Malone, often says, if you give women good information, they'll make good decisions for themselves, right? And so that's what we aim to do today. And so in terms of what's our objective today is to really hit on the most common questions that we see from our patients at Alloy, and that you and I both see asked over and over again, often the very same questions over and over again on social media, right? So we're going to hit all of those today.
We are.
And I think it's an important opportunity right at the get-go to have the listener understand, like, what does Alloy do? And why do we exist, right? Well, we exist because, less than 7% of primary care doctors, OBGYNs, internists feel competent to deliver evidence-based menopause care. They're simply not trained in it. We're not replacing your gynecologist. We're here to give access to evidence-based menopause management and access to menopause-trained physicians who know what they're talking about and are actually following guidelines, and to leverage telehealth to provide that access, to care. And we can talk in a little bit about actually the intake process and how we actually kind of technically do that at Alloy. But that's our mission. And then we deliver that access not only to getting an initial consultation and a treatment plan, but then continued messaging and access to, a menopause specialist, as long as you are a customer of Alloy.
Great, thank you. Dr. Menn, you and I had a back and forth ahead of this conversation, and you mentioned what you call gray zones, which you've just mentioned now, but sort of those things that sort of commonly asked, most frequently asked questions, and things that women may find particularly confusing for one reason or another. And as chance would have it, the questions that women shared with me ahead of this call touched on all of those topics. So just to kind of frame us out, things like endometriosis, progesterone intolerance, dosing, formulations. So we're going to get started now. I have a lot of questions for you, and we're going to dive in and when time allows, I will turn to questions that have come in here now live. This first question actually came in this morning and I love it. I think it's a great way to kick it off. She asks, can we get a consensus on what to call hormone use for menopause? It gets confusing trying to figure out every social media doctor's acronyms. Is it MHT? Is it HRT? Land this plane.
Well, listen, I think that we just have to accept that we are in a transition phase in this new menopause movement. And so, yes, there's an old school term of HRT. There's the new school term, which is generally preferred for MHT. The reason being is hormone replacement therapy signifies that we're replacing levels of hormones at what you had when you were in your younger reproductive years. There are times when we actually do full hormone replacement, and that would be someone who had premature menopause under the age of 40. They actually need higher doses. But we've moved towards a more, appropriate term, probably technically speaking, of MHT, menopausal hormone therapy. And we can talk about what that actually means and what actually does the different doses actually provide in terms of levels. And we'll put that into context later. So there's been this kind of philosophical shift. In the end, don't worry about it too much.
Yeah.
It's all hormone therapy.
Yeah.
Whether you call it HRT or MHT, think of them as really being interchangeable. And I think over time, more and more women are going to, and professionals will just start using MHT. And actually, in my mind, really, it should just be HT, hormone therapy,
Sure.
right? So it's an alphabet soup, but
Good. Thank you. So you brought up dosing. Someone did ask, and this is a specific question to her, but if you would kind of bridge that gap for us about dosing being a critical aspect of hormone therapy. This person's question is, what is too high an estrogen dose? She gave an example of what her dose is of a patch, which we can talk about later, formulations and so on, but she feels like she needs to go higher. So talk to us about dosing, talk to us about what's too high, what's not too high. How does your lay person know?
yeah. So I think this is like a very simple idea, is that we use the dose that treats your symptoms while minimizing side effects. And we do that using FDA approved, well-studied formulations and dosing options, right? So meaning that we don't have to stick to the lowest dose. No, we've got all of these different doses approved by the FDA specifically because it must be individualized, right? Now, so when is a dose too high? Well, a dose would be technically too high if a practitioner was not practicing evidence-based medicine and was giving you very, very high doses that are, not, recommended. But we have a wide range of formulations. And if, we can talk about, for instance, a patch comes in 5 different dose options, right? So, when a woman comes in, as a new patient, we're going to look at her whole picture. We're going to look at her age. We're going to look at her symptoms. We're going to look at how far she was from her last period. And then we're going to make a recommendation. And that's the art of medicine, right?
Right.
Now and then when someone has too high of a dose, they'll probably have side effects, right? So that gets back to this kind of general principle: treat the symptoms, minimize side effects. So, I always tell patients, how do we know what is the right dose? They ask, well, should we be checking blood levels, which I know we're going to get to, but this kind of touches on that. No, I'm not going to follow you based on your blood levels. I'm going to follow you based on your response. Because I can tell you, you can see women who are on the lowest dose patch and they feel great. Yeah. And I have patients who are on the higher dose of the patch, for instance, and they feel great. And they're both a similar age with a similar medical background. And patients, I want everyone to know that your dose is just one part of how you feel. Because remember, that dose has to be, and that formulation has to be either absorbed through your skin, or if you're taking it orally, it's got to get metabolized, it's got to get to your receptor. And then our receptors are all going to respond to that hormone in a different way. Some of our receptors need a little bit more, some need a little bit less. This is very individualized, and there's no one lab test that can tell you that. So we just listen to your body and your symptoms.
You know, Dr. Menn, I'm thinking as you're speaking about having been someone who's on birth control for years and receiving this messaging, incorrectly or not, that the lowest dose was the best dose because somehow higher was more dangerous. And I wonder how much of that has sort of seeped into the MHT piece. And so again, for the average person like myself who's questioning what to do, how to start, is it typical, is it appropriate that a doctor would say, well, we want to start you on the lowest dose no matter what? Or can we come back with saying something like, well, actually, can we talk about my symptoms? And maybe that'll inform where we land on my dose. What's appropriate?
Well, let's just separate out birth control pills from menopausal hormone therapy. And yes, we use birth control pills as a form of hormone therapy very often in the perimenopause. And when we're talking about dosing, whether it's high dose versus lower dose, when we're talking about oral synthetic estrogen in a birth control pill, we do have data that shows the higher dose pills that are more old-fashioned, that we tend to not use anymore. Really, all modern oral contraceptive pills are technically lower dose than they were historically, right? And so there was data showing that the very high levels of these synthetic hormones in birth control pills had a higher risk of blood clots, right? And so there is a dose-dependent risk there. But that's very different than the very, very low doses of hormones that are in menopausal hormone therapy. So while we're talking about dosing, let's just like make patients understand. I think it's important for women to understand what the difference is between a birth control pill hormone and a menopausal hormone therapy. Birth control pills are a potent synthetic form of the hormones that are powerful enough to stop the signal from your brain to your ovary. It tells you to stop ovulating. Your ovaries are no longer making its own estrogen. You're getting a daily even dose of a high enough level of, in a potent level of estrogen, that it suppresses ovulation, right? That's very, very different than giving back very low levels of menopausal hormone therapy formulations that are meant to not suppress ovarian function. It's not going to do that, but it's going to just treat symptoms, you know, and we know from large studies that even these very low doses given in the menopausal time not only relieve symptoms, but do have other health benefits when used appropriately and started at the right time.
Terrific. Thank you so much for that. That's very, very helpful. Let's now talk about formulation choices. There are various forms available, patches, pills, sprays, gels. Why does the choice matter? How do we women navigate the options, make decisions best for ourselves? And then I have a question specific from someone about that.
Good. So listen, there's lots of formulations out there. And I think women should understand that when we're talking about, let's just put the birth control pills aside and we can kind of talk about that separately. But in the menopausal hormone therapy range of treatment formulation options, let's just talk about the estrogen formulations first, because I think that's what people are most interested in. And we have oral estradiol, and we also have lots of different transdermal forms. And I brought samples today to show people, because not everybody has actually seen what these look like. So we know what a pill looks like, right? So that's oral estradiol. And then we'll talk about why we choose different ones. Here's the patch. Okay, this is a point. This is a 0.05 patch. Okay, so this is a patch that's changed twice a week. So it's very small. I'd say it's about the size of a nickel. The lower doses of the patch are going to be a little bit smaller. So the 0.025 patch is even smaller. but the 0.1 patch, which is double the amount of estrogen, is a little bit bigger. These are small and they're applied typically in the lower abdomen, changed twice a week. You can also put it on your butt. And the hormone is, absorbed via the skin. So that's one transdermal form. I'm going to show you each one of these, and then we can talk about how we choose them.
Sure.
Another, and I'd say all the transdermal forms are equivalent in terms of the benefit of a transdermal. So let's just say we choose a transdermal form in certain scenarios, but the number one scenario being women who are at an increased risk of a blood clot. All right.
And how do you know if you are?
So a couple of things. So first of all, everyone should know that just age alone, each year you get a little bit older, you just have a higher baseline risk of getting a blood clot. Forget whether if you're on hormone therapy or not. So there is just a baseline risk. When women are pregnant or in their postpartum time, they're at an infinitely higher risk of getting a blood clot.
Right.
Women who are on a birth control pill, risk is rare and low, but that's a much higher risk than even using menopausal hormone therapy. Menopausal hormone therapy has a very low risk overall, whether we use oral or transdermal. But what many studies have shown is that when we use a transdermal estrogen, there's no activation of clotting factors from the liver, right? So when you take an oral estrogen, it can produce a little bit increased risk of having more clotting factors and making your blood a little bit more. But that risk has not been shown to be statistically significant in a healthy woman under the age of 70. But we all know that there's lots of women under the age of 70 who have comorbidities, things like hypertension, high cholesterol. Maybe they carry an inherited mutation that makes them at a higher risk for clotting, like a factor V Leiden or a prothrombin mutation. Maybe they just have a really strong family history and they are just seeking something that is going to minimize any clotting risk, and then a transdermal would be great. And then there are women who are getting older. They're more than 10 years from their last period. And they just know they don't have any other inherent, risk for blood clots, but just age alone. And so that's where, as a woman gets older or she's on that like later range of wanting to initiate hormone therapy, we might say, hey, this might be a better choice. But if oral is going to work for your lifestyle and you like it, and it's sometimes a cost issue because the oral is generally less expensive, for the vast majority of women, that's an extremely safe, route. So I don't want a woman who is otherwise healthy, and particularly within the first 10 years of entering menopause, to have a fear that they can't use oral estrogen. It's extremely, extremely safe. And particularly oral bioidentical estradiol is been shown to be very safe and not associated with increasing inflammatory markers or anything else. But I want to go on and just show you
please.
even mist spray. So I showed you what the patch looks like. And while we're sticking on the patch, let's just talk a little bit. The patch, some kind of very common questions I get. Does it stay on in water? Yes. Can you shower? Yes. You can go in the hot tub. You can go in the pool. If you have a latex allergy, you can still use this, right? Now, are there some women who just happen to feel irritated by the adhesive in this? Yeah, it happens sometimes. And then we can switch to a different transdermal. Women also ask about having it like stick on. Some women have said, oh, I'm having a problem having it stick. There's a couple quick little tips. Make sure your skin is totally dry. You can even wipe it with a little alcohol swab, just in case your skin is a little bit oily. Make sure it's totally dry and then apply it. I think that's super helpful. And don't apply it right where your underwear line or pants would rub against it. So those are little tips, and then switch it. Like, so one time you put it on the left side, the next time you put it on the right. So that way your one area of your skin isn't always getting the patch on it. So those are some little.
Can I pause you there just for a minute?
Yeah, jump in anytime.
This person's question is actually pertinent to what you're saying, more or less. She asks that can women who sweat a lot or have the sticking issue for one reason or another be prescribed the patch in a way to change more frequently? This is an interesting question. And I
Yeah.
think
So listen, if your patch is not staying on because you're sweating and it's not working for you, let's find you another formulation. You know, you don't need the extra cost of changing it more frequently. And this is, again, you could start with a patch and you try it. And one of the nice things about Alloy is you have unlimited messaging with your doctor. This happens all the time. A patient will be like, Dr. Menn, I tried this for the past like 6 weeks. And I just got to say that like, I feel great for the first couple of days I'm on the patch. And right the day before I'm supposed to change it, I have some symptoms coming back. So this speaks to the art of medicine and listening to your body. Listen, these patches are shown to deliver the estrogen consistently up to 4 days. And then it kind of drops down, right? So that's why we just have to change it just every, twice a week. But we're all individuals. And some women, they might absorb a lot in the beginning, and maybe the second day or third day, maybe they're finding some symptoms come back. So there's a couple of things we can do. One, we can increase the dose. That could be a simple thing if they really like the patch. Otherwise, we're so lucky we've got 2 other transdermal options that are daily options. So then sometimes we switch to that. So this gets back to the very thing we said in the beginning. We're treating symptoms and minimizing side effects. And so there's not an algorithm for this. It's listening to how you feel on it, right? So does that make sense?
yes, it's so helpful. Thank you. And please continue with the other formulation.
Yeah. And so let me just show you here. So we get a lot of questions on this about the Evimis spray. I'm a huge fan of the Evimis spray, particularly in certain situations. So one is, well, let's just show what the Evimis spray is. So here's the spray bottle, okay? Because people say a spray, like, are you just spraying this estrogen? No, that's not how it works, right? So let's just show them. I didn't take my Evimis spray today. All right, so we're going to live demonstrate. Okay. So when you get the spray, let's just do some little practical things. If this is a brand new pump and you've not used it before, you do have to prime it by keeping the cap on, and you spray it a few times just to prime it, just like you would prime like a new moisturizer bottle or something. So you do that first. Okay. Then you take the cap off and you apply it to your inner forearm. Okay. And you hold it against your skin and you press down for 1 spray. I use 2 sprays a day. So if you're going to use a second spray, you move it. So it's not right on top of where you just sprayed. You move it and then spray it again. So now everyone can see it's been sprayed on my arm, and it takes about 90 seconds to dry. It's clear and it dries, and then you're good to go. Okay.
And you want to be careful not to.
Well, let me talk about
yourself. Okay, go ahead.
I'm going to talk about it because here's the common question. So common sense would say, don't spray this and take a shower.
Right.
Okay?
Right.
So, if you're going to do this in the morning, shower first. Or if you're going to do this and spray, and then you're going to go to the gym and work out, that's fine. As long as you're going to shower an hour later, that's fine. If you're concerned about that, just do it at night. It's okay. Do it before you go to bed. All right. So it's not spraying in the air, it's spraying right on your skin. That's number 1. The other very, very common question is people are worried, is this going to transfer to my partner, my child, my pet? Now, this is where common sense comes into play, because FDA labeling is going to say, be careful, transfer, cover it. This is medical legal stuff and kind of cover your that type of language. Okay. Now, this is what I tell patients. Unless you're having your partner, your child, or your pet spend 15 minutes licking your arm every single day after you spray it, or unless you're taking your arm with the spray and then rubbing it on your baby's face every single day, I think you're okay, right? If it's making you very nervous, and then this is not the formulation for you. So even if we tell you that you still feel nervous about it, then choose something else. It was studied on using in your inner forearm. You could technically try using it on, other parts, skin is skin. But we have the absorption studies from applying it here. So you are welcome to use it other places, but we do recommend using it here. So I'm not afraid of transfer to pets or partners. Just let it dry and move on with your day. So that's the spray. Do you want me to tell you which people I like the spray on, or do you want me to explain the next formulation?
Tell us, and then let's quickly get to the next, because I want to get to more of the questions, and I know
Perfect. So the reason, all right, so really quickly, the reason why I like the Evimus spray is because in this one spray, we can either do 1, 2, or 3 sprays. So, a patient can message their doctor and tell them how they're feeling, and then we don't need to send them a new prescription. They can adjust, and I can say, oh, go up to 3 sprays, or you've been doing this for 6, weeks, and you're having a lot of breast tenderness, maybe we can go down to 1 spray. That's one clinical scenario I like it. And I also love Evimus spray for perimenopausal women, because perimenopausal women, which this is touching on another theme we'll talk about, how to manage perimenopause. Many perimenopausal women, they are still making, of course, they're still making estrogen, but in waning in irregular amounts. And very often they don't need a lot. And so we can start with 1 spray, which is very, very low dose, and it's very flexible. And, as the months go along and their symptoms might change, they might say, oh, this month I'm having a lot of hot flashes and some night sweats, and I wasn't last month. Well, this month go up to 2 sprays. If the next month your ovaries are being a bit of, producing a little bit more estrogen and you're not feeling that, and you're feeling a little breast tenderness, go back down to 1 spray. So I find it's very, very flexible for women in perimenopause. So that's why.
Dr. Menn, really quickly to that, I've had women mention or ask rather, I use the patch or I take the pill. Can I add a spray of Evimus if I feel like I need more? Is there any blending of formulation?
Typically, I would
You would say no.
I don't combine different forms, right?
Great.
We would either just change the dose of the form you're on, or just switch to a different form.
Great, thank you.
Yeah.
Do you want to move on, or do you?
I'll just show you Divigel. So if you want something that's transdermal and daily as well, and you just don't want the spray, you don't like the spray, whatever, Divigel is really great too. So they come in, there's different doses. This one is the 1 milligram dose. This would be equivalent to the 0.05 patch, or roughly 2 sprays of the Evimus. And this is a daily gel that it's nice, it's easy for travel, right? Just pop up in your little bag, and you open up the little pocket, and you would just squeeze. I'm going to be well estrogenized today. You squeeze the gel, and then you just rub it in, right? It's a little bit more, it requires a more surface area. Typically, we recommend, I'm going to wipe this one off. Typically the gel is recommended to apply it to your inner thighs, because you just need a little bit more surface area to rub it in than the spray. So if someone says, I just don't like the idea of this being on my arm, and I might transfer it, if that's making you worried, then hey, Divigel is great, because you're going to put it on your inner thigh. I think you're rubbing that on people's.
Yeah, unless you're getting on a horse anytime soon, then.
Yeah, the horse can handle it. So I think that's great. And people just like the convenience of these small little pockets, right? The other thing that's nice about the Divigel is that if you were having some, say, breast tenderness or some spotting, and we wanted to lower your dose, we could very quickly lower your dose by just telling you to just use half of this packet, and then we could change it to, a different, because there's like 5 different dosing options here. So we've got a lot of flexibility with the Divigel. The other thing I will also say, and this is why having access to a menopause specialist at Alloy, and not just seeing a doctor who doesn't really know the nuances, is there's lots of little tips and tricks about when these different formulations, when it peaks, if you're having nighttime symptoms versus daytime symptoms, there's lots of little things we can do. Like, for instance, the spray peaks around 2 a.m., the gel peaks a little bit earlier, the patch is great for people who have, migraines, who need a very steady, slow, given over many days. So there's all these little kind of nuances that a menopause specialist can really know. And if you're messaging with your doctor, they'll help you figure that out.
Fantastic. Thank you. Okay, I'm moving us on to the next question, and hopefully this covers a lot for people with endometriosis or fibroids. What's the safest dose of or route of administration of MHT for women with endometriosis or fibroids? Should these women get annual vaginal ultrasounds if they use MHT, or is this not necessary? Is cramping, bloating a concern? especially with, I might pronounce this wrong, adenomyosis.
Adenomyosis. So let's take these. Yeah, let's take these three separate things. These are super common questions. Endometriosis. These women are often dismissed and denied access to hormone therapy, and they should not. Endometriosis is very, very often treated, sometimes medical management for many years, but many women have surgical management of their endometriosis, and they might have only their uterus removed, or they might have their uterus and their ovaries removed, very often prematurely. So if you still have a uterus and you have a history of endometriosis, you will be prescribed estrogen and progesterone, and we will give you the dose that treats your symptoms and minimizes side effects. It is reasonable in someone with endometriosis to start lower, right? That's okay, because we know if you've had surgical management of your endometriosis and they've removed all the little endometriosis implants, and they may have also removed your uterus, that adding back estrogen, there's a theoretical risk that if there was little tiny endometriosis implants that were left behind after surgery that are still present, there's this theoretical risk that they could be stimulated a little bit, causing cramping or pain, right? And so I think it's reasonable. You could start a little bit lower. But these women should not be denied access to hormone therapy, and many of them are wrongly. The other little thing about endometriosis is that if you had advanced endometriosis, meaning a lot of implants or adhesions, scar tissue on your bowel, on your bladder, or they maybe left some behind because it was so extensive, even if you don't have a uterus, we recommend you also having progesterone, because it may, kind of counterbalance the estrogen, maybe stimulating any remnant endometriosis implants. So we will often recommend, hey, you don't have a uterus, but you had endometriosis that was severe. Let's give you progesterone. But large studies have looked at this. They were not randomized controlled studies, but the large bulk of the medical literature supports the use of hormone therapy. And I want to just, for anybody listening about endometriosis, many of these women have only had their uterus removed. Their ovaries are still intact. Anybody who has only had their uterus removed, they're at risk of going into menopause at least 2 or 3 years earlier, sometimes more. And women are never told that. And since they don't have a uterus, they're not having the bleeding changes. They need to be on the lookout for other menopausal symptoms or perimenopausal symptoms, so that they can say, like, hey, I think this is happening to me, and it's happening a little earlier, and you can get hormone therapy, right? Okay. So that's a quick step on endometriosis. So dose formula, endometriosis patients can take oral, they can take transdermal. We're going to base that based on their preference and any other medical history stuff. Fibroids. A history of fibroids is not a contraindication to hormone therapy. The levels of estrogen in menopausal hormone therapy are not going to make your fibroids grow. It's universally, it is safe, okay? Same with adenomyosis. If you had adenomyosis in the past, we can give you menopausal hormone therapy. It's not going to make your adenomyosis grow. Understand that in perimenopause, fibroids and adenomyosis sometimes flare. And that's because what happens in early perimenopause is that we get a lot of estrogen being produced, and our ovaries aren't always ovulating. We don't always get progesterone. So times of perimenopause are actually times sometimes of hyperestrogen. There's a lot of estrogen being produced and not a lot of ovulation or inconsistent ovulation. So women might find that their fibroids have grown a little bit in their 40s, or they've gotten this new diagnosis of adenomyosis. That's where we can step in and help these women, either with a birth control pill to stop that crazy irregular up and down secretion, or we can start giving them back some progesterone only in a very low dose of estrogen if their hormonal fluctuations of their estrogen are giving them times where the estrogen dips really low and they're having symptoms. So none of these adenomyosis, fibroids, endometriosis, none of them are contraindications, but they help the doctor with nuance in decisions about kind of which kind of dosing and how to give it. But across the board, these women are often denied access to proper menopause care, and many of them are going through menopause early. So they're a vulnerable population that really needs support at this time.
Thank you so much. You're fantastic, Dr. Menn. All right, I'm going to pivot us to another topic that comes up often, particularly of late, duration of therapy. Now, if you could just spend a brief moment talking about continuing menopause hormonal treatment past 60, starting menopause hormonal treatment past 60. And then I have 2 questions from listeners I want to give to you.
Okay, super quick. Remember, let's talk about things, the timing in this duration in 2 separate buckets. One bucket is the ideal window to initiate. And let's get rid of the 60. That bothers me actually.
You know, it's such a
10
hard
years, it's 10 years from your last menstrual period. Okay. So if you were, so the average age is 51, right? But there's many women who are 53, 54, 55, 56. So if your last period was at 53, your ideal window of, like I say, getting the most bang for your buck in terms of long-term preventative health benefits, it's going to come if you initiate hormone therapy early in that time, ideally the sooner rather than later, but within the first 10 years. That's what all of the data says. So that 10-year window is different than duration of therapy. Okay. So I hope that clears that up. And so 60 should not be used. You don't magically turn into a pumpkin at 60.
Right.
So that's one thing. Then duration of therapy is a different concept. Duration of therapy is you've started it at whatever age, you're doing well. And patients ask, well, can I stay on this? Right. And so these are the common things that I see patients being told wrongly, right? One is, I've hit 60 now. My doctor says I must come off it because the doctor somehow has learned this idea that 60 somehow is this like cutoff point. We just explained 60 is not the cutoff point. 65. Okay, you're 65 now. So you have to stop it now. Actually, no. And the Menopause Society did a very good thing in their 2022 position statement is they got rid of this language about having to use the lowest dose for the shortest amount of time, because that language was actually not based on really any science or evidence. They evolved and they said, listen, the data supports that it should be an individual decision and that longer duration is not associated with more risks. So it should be a decision that's made between the prescribing physician and the woman, and based on how is she feeling? Does she have any new contraindications to hormone therapy? Is there anything in her medical history or perhaps with her advancing age that might suggest that, hey, maybe we want to switch to a transdermal, or, maybe you want to go on a lower dose to see, but you don't have to, right? If you're doing well, you have the agency to stay on it as long as you like. And then the other interesting thing that I see come up a lot is women who were started on hormone therapy. So say they were like 52 years old, they took it for 5 years till age 57. Some doctor made them come off of it. They said it's been too long. And now it's been 4 years and they haven't been on it. So, let's make them now, they're 62 or 63, right? Or even older, right? I'm going to look at that person a little bit differently than someone who went through menopause at, say, 51, and now she's 63 and she's never taken hormone therapy, versus someone who is maybe more than 10 years from her last period. She had a few years of hormone therapy, she had a few years off, and now she wants to restart. Those are different patients. One patient had extra years of some estrogen exposure and some estrogen protection, basically, on their cardiovascular system. She's not estrogen naive, as we would say medically. She's had some exposure, right? She's a little different than someone who's gone 13 or 14 or sometimes 20 years without therapy. I saw a patient recently who was 80 and she was on hormone therapy for 30 years and she did beautifully. And at 80, her doctor retired. She was denied access to her care and she had all her symptoms come back. She was very upset. And she had been on oral Premarin for 30 years and did beautifully. There's no reason to deny that. So yes, I restarted hormone therapy, but she's not the same as an 80-year-old who comes to me and has not had any hormones for 30 years.
Yeah.
Those are very different scenarios.
So Dr. Menn, that was actually a question almost verbatim from someone I heard from, who also added that she's now 66. She has osteopenia, wishing she'd never stopped and having trouble accessing. She's not in this country, but it sounds like she was someone who used MHT for several years, reaped many benefits, was asymptomatic, and should she be able to find someone to help her, can start MHT again. Yes?
Yes. So here's a great example of looking at the individual patient. So somebody like her, what we can tell her, what the data says about preventative health benefits. We've already established, and we've done other webinars on this before, that there is an ideal time frame of initiating hormone therapy in terms of two major things: cardiovascular disease protection and dementia decrease. And it appears the data is quite powerful that when we initiate it early. The third big preventative thing we talk about with hormone therapy is bone health, right? And while when you've gone more than 10 years from having any estrogen exposure, you can still initiate hormone therapy if you have an individualized discussion with your physician, right? But we're going to tell you that we may have lost that window of opportunity for kind of the same type of cardiovascular protection. But we actually have data on women for bone health. They're osteopenic, they're 65 years old, either they were on hormone therapy or they never were. The data actually shows we can use very, very low doses of estrogen, meaning the smallest dose, just like one spray or the lowest dose patch. And actually studies have shown that those women will benefit from, halting further bone loss. And she certainly will benefit if she still has symptoms. Many times the hot flashes and night sweats may have gone away, but there's other symptoms, because we're more than just hot flashes and night sweats. There could be aches and pains and sleep disturbances and other things. And she could have a trial to see with like, hey, is it helping some of these other symptoms? But let's remember, hormone therapy is FDA approved for the prevention of osteoporosis. That's one of the primary FDA approved indications. So if that's the indication that you'd like to use it for, you should have that option.
By all means. Thank you.
So someone who's osteopenic, it's approved for that. Once you're osteoporotic, right? It's not that using hormone therapy is wrong or bad, right? It may be helpful so that you don't have further bone loss. But once you're osteoporotic, you need to speak to a board certified endocrinologist who understands bone health so that you can do the full picture, because there might be other medication tools that you would use to prevent further, your risk of fracture.
Terrific. Thank you. Dr. Menn, I want to pause for a second. We have a lot of other questions to get to, and I want to give you a moment to quietly think to yourself if you can give us an extra 5 minutes while I ask you this.
I'm fine. Yes.
Terrific. Awesome. Thank you. I'd love to get through this. Thank you. Okay. Here's another question pertaining to the over 65. This person says specifically. She said she was able to obtain and read the new preprint about MHT over 65. She goes on to say, as you just did, about estrogen and its many health benefits. However, she says it seems to show more risks than benefits for estrogen plus progesterone over 65, if I'm interpreting correctly. That said, they didn't look specifically at low dose transdermal estrogen plus low dose oral progesterone. So what say you?
So listen, she's referring to this very interesting and important study that was just published in the Menopause Journal, where they looked at, and let's just make everybody clear what this was. They looked at 10 million senior Medicare women's Medicare claims. They did not look at patients' medical charts. This was not a randomized controlled study looking at different types of formulations saying which one's better than, but it was, the strength of the study was that there were 10 million claims, but these are just Medicare claims, right? So it's not the same as looking at a chart and understanding that. And what I think when we are looking at data, this is how I'm trying to explain this to patients. We look at like, does the data support what the other data has suggested for decades, right? And in this this important study. It showed that women who were using estrogen alone, who didn't have a uterus, it showed support that they could continue on past 65. So it looked at women who were either on hormone therapy and never stopped, and versus women who were never given the opportunity to be on hormone therapy. And it showed that these women, from cardiovascular to bone to breast cancer to colon cancer to other cancers, blood clots, heart attacks, it was just across the board beneficial, which lends a lot of support to what the Menopause Society position statement said, was that longer duration does not increase risk.
Right.
The other thing that a lot of people saw that, you know, people get confused on is they also then looked at, well, what about when it was estrogen with progestin? And again, remember, this is looking at lots of claims and there's lots of different formulations. And it showed a small, a 10% increase association with a breast cancer diagnosis when women used a progesterone with an estrogen. But curiously, if they use a synthetic progestin with a transdermal estrogen, it didn't see that. And so these numbers that were presented, remember, these are the percentage. It was a 10% increased risk with progesterone and a 19% with a progestin and certain estrogen formulations. But these were not, this is not absolute risk numbers. We've actually asked the authors to provide us with the actual numbers versus just these percentages so that we can put it into an absolute risk for an individual woman. And so there's a lot of data in that study. And I think the take home that I want women to know from that study is it supports that longer duration has so many benefits, and we must weigh those benefits against any risks. And we are more than just our breasts. And even and I think the reassuring thing was that when women use progesterone, in that risk was very, very small, and it needs to be balanced against all of the other wonderful benefits. So, you know, everything has to be, you know, spoken of in perspective.
Nuance and perspective. Yes, thank you. Okay, I'm moving us on. You sort of touched on this already, but just to put a pin in it, contraindications for MHT with a previous pulmonary embolism.
So listen, this is the nuance of individual cases. When we're looking at blood clots, because we get this very frequently, women have either a history of a pulmonary embolus or a deep vein thrombosis. The very first thing that the doctors want to get from the patient, and we ask patients this, is what was the scenario that it happened? Was it a provoked or was it an unprovoked? Provoked means, was there something that is obvious that caused it? Some very, very common reasons would be a car accident or some type of physical trauma, which can cause like a blood clot in a leg, and then it can travel to your lung. Another common scenario is a postpartum hemorrhage or a very difficult obstetrical delivery, or a very, very prolonged surgery after someone was immobilized and they couldn't move. They're at very high risk of a clot. Those women have something called a provoked, that's a provoked DVT. And those women may be counseled that they can safely take a transdermal estrogen. There's a lot of studies, the most important called the ESTER study, that looked at oral versus transdermal, showing that transdermal had no association with increased blood clots. Some women may have had a blood clot when they were taking an oral synthetic birth control pill. Younger, and then they're told they can never have hormones again. That's not necessarily true, because in those cases it might be considered that was a provoked thing. So we have to get some further answers, and there are patients who are well counseled who can take it. So I don't think it's an across the board absolute no. We need more information. And I'd say maybe half the cases they could actually be counseled that they could. And so, yeah.
Okay, thank you. Next question hovers on testosterone. I've been prescribed compounded testosterone and estrogen. Is compounded testosterone okay to apply to the labia or the vestibules for extreme GSM? And do you want me to stop there or hit you with the next one?
All right. We'll hit me with the next one. We'll hit testosterone ones.
What is the best and safest form for women to take testosterone? pros and cons of any of them.
Great. So first, just want to get off the bat at Alloy, we do not prescribe testosterone, not because we as menopause specialists don't know that it can be an important hormone to add. It's that you can write to the FDA and the DEA. They classify testosterone as a controlled substance similar to a narcotic. There's extremely strict rules about how we can prescribe it via telehealth, and there's not an FDA approved version for women. It's a huge problem. Number one. Number two, testosterone, just like estrogen, we've got vaginal estrogen, that is local vaginal estrogen for just genitourinary syndrome of menopause, not systemically absorbed. There's also systemic estrogen in patches and pills. This question comes, they're asking two separate things. One is there's a systemic use of testosterone, and we know the primary reason why we are advised by our medical guidelines and medical societies is to use systemic testosterone replacement in a transdermal form, either in a compounded gel or cream, or using a male version, but in much smaller doses of a gel testosterone form. That's systemic testosterone. Primary indication is for low libido. It's the next frontier. Menopause specialists and sexual medicine specialists know there are other benefits of testosterone that are beyond this discussion right now. But the primary indication would be for low libido. The person who asked that question was also referring to the use of testosterone locally on the labia for genitourinary syndrome of menopause. The answer is yes. In refractory, if you have tried vaginal estrogen and it has not worked for you, my first question is always like, how were you using it and what were you given? Because when people say vaginal estrogen didn't work, I tend to not believe that they were being instructed how to use it properly. Many women are prescribed Vagifem tablets twice a week, a little dry tablet. They're told to put it up in the vagina. Do you think that that is going to help someone with severe external genital atrophy in the labia, the clitoris, the vaginal vestibule? No, it could be a lovely option for someone who just needs mild symptoms or for maintenance therapy. Hence why the topical cream is really lovely, because you can insert it up inside, which we recommend so it gets into your bladder, but you can also rub it on the labia. So if patients have tried that and they're still refractory, sometimes sexual medicine specialists, urologists, menopause specialists may prescribe a local low dose of testosterone, not for systemic therapy, but to just treat, particularly on the outside, right at where an episiotomy would be, that's called the vaginal vestibule, that area. But first, you can apply vaginal estrogen. And what's interesting is that vaginal estrogen, gets absorbed into those cells there and will work on the receptors and should improve things. There is an FDA-approved vaginal DHEA, it's called Intrarosa. That is also a local hormone, not systemically absorbed, that then gets converted to testosterone and estrogen within the receptors. Problem is, it's a brand name only, it's expensive, it requires pre-authorization. So we generally start with the vaginal estrogen, and I'd say 99% of the time that works. But if it doesn't, it's something that, could be considered to be prescribed. But again, you have to think about it in two buckets, local versus systemic. And then the third way that we would use local testosterone, sometimes we will compound a low dose testosterone and estrogen combo vaginal cream or gel specifically to be used externally. And that can be very, very successful in patients who are refractory to the estrogen treatment.
Thank you, Dr. Menn.
And pellets are not a safe delivery of testosterone. So ladies, you can come get your hormone therapy at Alloy. We'll help you with estrogen and progesterone and vaginal estrogen. If you need to get testosterone at this time, we can't give you systemic testosterone, but we use ISWISH, International Society for the Study of Women's Sexual Health. This is the governing body or medical society that makes excellent recommendations on the use of testosterone. They do not support, neither does the Menopause Society support testosterone pellets, because once those pellets go in, we can't take them out, and you can have very, very high levels of testosterone. It's also extremely expensive and lots of unnecessary testing.
Thank you. Dr. Menn, just to close the loop on vaginal estrogen, which you spoke about so well, thank you. A lot of questions, a lot of confusion around, can I use vaginal estrogen when I'm also using transdermal or oral estrogen? Is it too much? Is it problematic? Can you
Yeah.
just
Yes, this is very important. I definitely want to get to this. So vaginal estrogen is safe with birth control pills. It's safe with systemic hormone therapy. It's safe whether you are 40, 50, or 80. The bottom line is vaginal estrogen is local, not systemically absorbed. We can use it in all ages, and we can use it in women who are otherwise contraindicated from using systemic estrogen, right? So breast cancer survivors who may not have the option to use systemic hormone therapy, that's a separate discussion. Someone who truly has this complicated cardiac history where we've made the decision it's not in her interest to use systemic estrogen. All of those scenarios, we can use vaginal estrogen. And many women who are on the birth control pill, this is very important. The birth control pill is a wonderful option in the perimenopause to help control symptoms and give you birth control. But in a small percentage of patients, it will cause more vaginal dryness because the birth control pill does lower testosterone levels and can cause vaginal dryness. And it is very safe to use a birth control pill and some local vaginal estrogen cream. It can be a real game changer. And can I just show, because I like props.
please, yes, demonstrate.
So, women want to talk about vaginal estrogen cream. It comes with an applicator. People either love this applicator or they hate it. Most people hate it. Why does it come with an applicator? Because we want to push the vaginal estrogen up into the vagina so that some of the estrogen gets absorbed into the bladder wall. Problem is you're putting a lump of cream into an empty cavity, right?
Yeah.
And we wonder why it doesn't all get absorbed because they wake up in the morning and this is sitting in their underwear. So I just measured out 1 gram, okay, of vaginal estrogen. So let's see what this looks like on my finger. That looks like this much. You could figure that out. It's like an inch, right?
Yeah.
You could put this on your finger. So you could put this on your finger. You could put your finger in the vagina and you can rub the vaginal estrogen into the wall of the vagina that faces up towards your belly button or towards your bladder. That will ensure that it's going to be absorbed into the bladder. You're going to have a bunch left over on your finger. So then when you come out, you can take it and rub it onto the opening of the vagina, on the labia, dot it on your clitoris, wash your hands. You just did skincare for down there, just like you do skincare for up here.
Yes. And it's preventative care. Please understand.
And also
that.
call it a day. Then it's not going to leak out because guess what? You just rubbed it in. Do you put a dollop on cream on your forehead and hope that it just doesn't drip down your face? It's the same thing with vaginal estrogen. Just rub it in and move on.
Thank you, Dr. Menn. Next, managing common side effects, a very, very, very popular question. It's essential for ensuring patients' comfort and adherence to hormone therapy. Break it down for us.
Super easy. Most common side effects whenever we initiate hormone therapy or a birth control pill. This is the same thing we tell young women when we start them on a birth control pill. Breast tenderness, bloating, some irregular spotting and bleeding. Super common. I'd say up to 80% of women might, experience one of those or some of those symptoms. And the symptoms can come from the estrogen part or the progesterone part. So again, we have to listen to the patient and let's go through each of them. Breast tenderness. First of all of these side effects tend to go away in the first few weeks or the first couple of months of being on it. So if it's mild, it's not really bothering you that much, and you're otherwise feeling good in terms of symptom relief, you could just stick with what you're doing. If any of those symptoms are bothering you, right, we can look at the estrogen dose if we're talking about menopausal hormone therapy, and we can lower the estrogen dose because certainly bleeding and breast tenderness in particular tends to be dose related. So if you're on a pill, we can break the pill in half or call you in, send you a lower dose of the pill. The patch, we can lower the dose of the patch, lower the amount of the sprays. Sometimes a doctor, if you're at home and you don't want to wait to get a new patch, we can tell you, we can cut. These patches actually can be cut. The ones that are used twice a week, they can be cut in half. You could just use half a patch. And then if you're going to stay on that dose, we would just send you in the proper lower dose. So very, very easy to adjust the dose down if we need to. Progesterone has its own side effects. It's not always the estrogen. The common side effects to progesterone would be bloating or some GI distress. And I want everyone to understand why. Progesterone is a relaxing hormone. It relaxes the smooth muscle in the GI tract, right? So it can relax the muscle. So if you have a history of reflux, cause a little bit more reflux. You could feel a little bit more bloated. For some women, this is really just transient and it tends to go away. But if it's persistent and it's bothering you, we're going to maybe change your formulation to something different. There are synthetic versions of progesterone that we can use. We can also off-label use oral progesterone vaginally. The capsules are oil-based, they're fat-based, and so I should say fat-based, oil-based, and they actually absorb really well. So here's a little tiny progesterone capsule. You need to speak to your doctor about this. This is an off-label use of progesterone, but it is commonly used vaginally for women who just can't tolerate orally because they have that GI upset. Okay. We don't need to send a special version of the progesterone to use it vaginally. We can use an IUD, progestin IUD in perimenopause. This is not the IUD, this is the inserter device, but this is obviously what you see it, the IUD looks like. And that's beautiful because it's just providing the progestin right in the uterine lining. So that's another great kind of option if you're not tolerating a progesterone. The other common problem with progesterone is people love the side effect that it makes you sleepy. Some people it makes them too sleepy. The very first thing I tell women is take it a little earlier. If you're normally taking it at 10 p.m. or you're going to bed at 11 p.m., take it with your dinner or after dinner at 8 o'clock. And, it'll often wear off by the time you wake up. And so that can help. And if you're on 200 milligrams, sometimes we'll decrease you to 100 milligrams, or we'll change the formulation to a synthetic version. At Alloy, we have a combination pill that's an oral bioidentical estradiol paired with a very safe progestin called norethindrome, which is a progestin that is used commonly in a birth control pill, but in a lower amount for menopausal hormone therapy. Very, very safe, very effective way, and a great solution for someone who can't tolerate oral progesterone.
Dr. Menn, you're amazing. I'm trying to be really mindful of your time and also take advantage of your knowledge. So if I say quickly, I'm not telling you to go fast. I'm wanting you to.
Yeah. I get it.
Next question is about sleep, actually, and progesterone. This woman writes, I'm late perimenopause, have an IUD, take 200 milligrams of progesterone, and I'm on the patch. I'm paraphrasing, but essentially she goes on to say it is not helping her sleep. And she hears about the benefits of progesterone for sleep ad nauseum, and it's really tough for her. She has good sleep hygiene. What might be the issue?
There's a couple of things, and obviously I don't know her specific case, but sleep is, it's more than just falling asleep. It's often waking up in the middle of the night. Progesterone is very good at helping women fall asleep. But if you are waking up in the middle of the night, it tends to mean that you need more estrogen.
Okay, I'm so glad you said that, because that was
you're probably having vasomotor symptoms and hot flashes. Women have to understand sleep disturbance comes from, yes, being woken up by a hot flash or a night sweat, but sometimes it doesn't have to be an overwhelming, I'm sweating and, soaked. It could just be like, I'm woken up and I feel a little anxious, or I feel a little like a warmth or something. And it could be pretty mild, right? And so if it's waking up in the middle of the night, I would talk to your doctor about maybe increasing your estrogen dose, or this is where, formulations come into play. The spray, for instance, peaks at 2 a.m. Or maybe that's not working for you. Maybe you want to switch to the Divigel and you take that Divigel right before you go to bed. So then you've got that peak there. So there's different ways to play around with it. And in the perimenopause, remember, things are evolving. So what worked for you a couple months ago may not be working for you now.
Terrific. Thank you so much. Thoughts on oral progesterone when a hormonal IUD is in place? Should she have it removed? Yeah.
Listen, if you are perimenopausal, and you've got a Mirena IUD, it is doing a beautiful job for you of giving you contraception, and is really going to make your bleeding very light and, manageable most of the time, right? But people have to understand a progestin IUD does not necessarily suppress ovulation. Maybe 50% of the time it does. A progestin IUD does lots of things to prevent you from getting pregnant, but suppressing ovulation and changing what's happening with your actual hormones, it doesn't really do that, right? So a woman can have a progestin IUD, their ovaries can still be making up and down, amounts of estrogen. So women can have all sorts of perimenopausal symptoms. But one of the most common symptoms in women in perimenopause is an increase in anxiety, sleep disturbances, breast tenderness, bloating. This all comes from them producing estrogen, but they're not always ovulating every month and they don't have a lot of progesterone. Be clear, the Mirena IUD or the hormonal IUD does not have progesterone in it. It's synthetic, safe progestin that is only acting in your uterine lining. You do not have to use progesterone, right? It's we give you estrogen, that progestin is going to protect your uterine lining. But that is the only thing besides birth control that IUD is doing for you. And I love it. There is no reason why in the perimenopause you can't add in. I often start these women on 100 milligrams of progesterone at night, and they can go up to 200 milligrams. Even in the Menopause Society physician statement says women studies have shown they can go up to 300 milligrams if needed for sleep. So I always tell women, you don't have to use progesterone, but we can add it if you need it. And if the woman has a Mirena IUD and she comes to me and I see she writes, my sleep is the biggest problem for me, I'm going to offer her progesterone right from the beginning because that's what she needs.
Thank you. To close the loop now on progesterone intolerance, could you help us understand why some women would experience that and how it sort of impacts their hormonal journey, I guess, if you will?
Listen, I don't know if we have a specific number. I'd say about 10%, I'm just guessing, about 10% of women will just say, I've heard all this wonderful stuff about progesterone. It's just not working for me. So back to what I said earlier, we've got a couple of ways to talk about it. The first thing I asked is, was it just like mild kind of that intolerance in the beginning, a little GI upset or a little bloating? If it's mild, I say, listen, stick with it. You haven't seen hormones in a little bit. Maybe you've been menopausal. You might need to just adjust. So that's number one. Number two, if it really seems like, listen, as soon as I take this, I either have lots of GI stuff going on, or it is making me way too sleepy, which we know it can do that, and many women like that. Then the next thing we talk about is what I mentioned, either switching to just a different formulation using a synthetic progestin, or working with your doctor and maybe using it vaginally, or working with your in-person gynecologist and having them place a progestin IUD. Why does it happen to someone and others? I think this comes down to receptors. We don't actually know because nobody studies progesterone very much because there's no money to be made on bioidentical progesterone. The pharmaceutical companies, this is a generic medication, right? So there's not a lot of studies done. But it comes down to receptors, Rachel. Your receptor in your body, how it responds to progesterone at the receptor in your GI tract or in your brain is going to be different than someone else. And for some women, it just makes them feel too sleepy. And I want women to not be afraid of the synthetic progestins. They are safe options that have been used for decades with millions of women. And, we always have to balance risks, benefits, what's going to work best for you. I know many a menopause specialist they are taking oral estrogen and oral synthetic progestin in the combination, generic Activella, that's one of the medications we have here. They love it. They've been on it for years and they will stay on it because it's a safe and effective option. So women should not be afraid of using the non-bioidentical progesterone options.
Finally, Dr. Menn, you are a breast cancer survivor. You talk about breast cancer. You work on behalf of, you are an advocate for women who have had breast cancer, may ever have breast cancer, and any other type of cancer. This isn't that conversation about the specifics around cancers. However, there is never a call. There's never a webinar. There's certainly never any post you might drop or I might drop about the use of MHT that doesn't trigger questions about safety, efficacy, and breast cancer specifically, often uterine cancer is another one, endometrial cancer. I would just love it if you would kind of leave us with a word or 10 about what you would have us know, women who haven't yet been touched by it, it may be women who have been, about how to sort of think about relieving symptoms of perimenopause and menopause, and real genuine concern about their health and a life with cancer actively or in the past.
Most common question, we all get, and whether it's a breast cancer survivor or someone who is at higher risk. So let's separate out two buckets. If you are at higher risk of getting breast cancer because of a family history, a BRCA 1 or 2 genetic mutation or other mutation, a history of breast biopsies that showed some abnormality, that's a separate bucket. You've not had invasive breast cancer. We can help you at Alloy. We've got clear Menopause Society position statements that the overwhelming preponderance of evidence supports the notion that hormone therapy, treating your menopausal symptoms and using appropriate FDA-approved hormone therapy, does not further increase your risk. If your risk is here and this person's baseline breast cancer risk is here, whether we give her hormone therapy or not is not going to change that risk. Why is it important? I want all women to know their inherent baseline breast cancer risk. I want them to know that so that they know what's the best screening and surveillance for them and what options they have to lower their risk. But that is a separate discussion than someone being told they are denied access to menopausal hormone therapy. And I'll just end that kind of bucket on saying that luckily the Menopause Society does have a beautiful practice statement that they published in 2016, which was supported by a beautiful paper that was published in 2023, looking about the risks of hormone therapy on BRCA carriers. Okay, these are women who have not had cancer, but we know they have an up to 80% risk of getting breast cancer at some time in their life. The data says these women should not be denied hormone therapy, even if they have intact breasts, even if they did not have a prophylactic mastectomy, because many of these women, including our own founder, Monica Molinar, had their ovaries removed prematurely to lower their risks of ovarian cancer, and then are left in the lurch of premature surgical menopause. Those women can have hormone therapy. So that's a separate discussion. Then we've got the women who have actually, unfortunately, like me, been diagnosed with breast cancer. At Alloy, we can take care of all of these women with systemic hormone therapy if they've not had breast cancer. You and I both know, as do our listeners, a breast cancer survivor's decisions and options on whether or not she takes hormone therapy after her breast cancer diagnosis must be individualized. It's complicated. They need counseling. We need to review their records. Sometimes we need to coordinate with an oncologist or their other medical doctors. So we want a team approach. They need true informed consent. And that takes a different level of care and time. We are working on ways that we can give that access to the breast cancer survivor, because there are 6 million breast cancer survivors in the world. That army of survivors is growing, and we are ignoring these women, not we at Alloy, but this
Collective medicine.
The medicine is kind of just leaving these women out of this menopause movement, and it's not appropriate, and it's a huge problem. What can we do for these women? One thing is, at Alloy, we can give these women vaginal estrogen, safe local vaginal estrogen. No woman on earth should be suffering from painful sex, urinary symptoms, vaginal dryness and pain. Nobody should be suffering. We can treat you with vaginal estrogen. We can offer you some non-hormonal options to treat hot flashes and night sweats. But the other value for a breast cancer survivor to come to Alloy, even if at the current time we do not prescribe systemic hormone therapy for these patients because they need a whole nother level of counseling, is that we can provide them with rich resources, education opportunities. And sometimes I do try to help get these women to clinicians, who might in their state, who might be able to help them. And it's often way more information than they've ever been given by their oncologists or their general OBGYN. And yes, people will hear me speak about that I use hormone therapy, and I am a breast cancer survivor. And it took me many years to do that. And we can have another webinar on that if you want. And it's a decision that I made with my doctors and with my own knowledge. It took a long time coming. And there is data out there, and we when I have a breast cancer survivor come to Alloy, I give her, and all of the doctors do, we have, lots of resource links, including access to full text copies of what the latest research shows about hormone therapy after breast cancer. And I think depending on the patient, depending on her case, it may be an option for her. And there are also non-hormonal options and other things in the menopause toolkit that a breast cancer survivor may need to lean into even more than the average woman. So it's not an easy answer, but it's an honest answer to this is where we are right now. Anybody who got this far into the webinar and might be a breast cancer survivor out there, the most beautiful, amazing resource that I have ever seen is a woman out of the UK who has a wonderful Instagram account and a nonprofit called Menopause and Cancer. I've done a bunch of webinars with her. If you want one place for evidence-based
Danny Binghamton.
Danny Bennington,
Yeah,
she's
I've
an
spoken
incredible
with
human being.
wonderful.
She's a breast cancer survivor. She has all of the experts on, and she really leans into the whole.
Oop, everybody froze.
To be denied access to hormone therapy just because you might have a higher risk of breast cancer. And if you're a breast cancer survivor, there are some things we can help you with. There are some things we are working on to provide you with a higher level of care. And at the very least, we can help point you in direction and give you some support.
Dr. Menn, I'm sitting here sort of containing my giddiness. You're just phenomenal. And we're so lucky to have you as a part of this world of Alloy. You're just an incredible voice of reason and passion and real scientific information. You appreciate the artistry and the nuances necessary to care for, treat, and educate women well before perimenopause and well beyond. Thank you so much for giving us an extra 20 minutes of your time today. I do hope that we get to schedule another conversation soon. Thank you to everyone who came. I know there were many questions that were dropped into the Q&A, and I was scrolling through them and realized there were many overlaps in things that we talked about. So I do apologize today for not having gotten to those questions.
And you know what, Rachel, you can send me those questions and it's fun. I can answer some of them. I'll do this weekend. I'll answer some of them on maybe Alloy's stories this weekend on Instagram. So we can do that. And I save them for inspiration for future reels, and we can certainly do another webinar. And
I do want to just quickly remind people, everyone, Dr. Menn, that this call and all other webinars are uploaded to our YouTube, Alloy Women's Health. We have a channel. Please subscribe. I'm going to talk about it later. I know Dr. Menn's going to talk about it later. It is an incredible resource. It's a real library of information that's free and accessible to everyone. The conversations that are living there are critical to the experience of women in perimenopause, premenopause, postmenopausal life. Please do.
Unbelievable, Rachel. It's the Alloy YouTube channel is a free masterclass series with literally every leading specialist recorded for an hour with each of them. Lean into that.
Or in this case, an hour and 20 minutes. I'm stopping.
And then the last thing I want to say is, people see me on Instagram or that you hear in the webinars. We have a whole team of other doctors at Alloy. They're not all on Instagram, right? They're amazing. And that's what I'm jumping onto next. And I want the listeners to know that the doctors at Alloy, we meet every single month and we have our own group kind of, thread on that we exchange pearls and tidbits. We support each other. We review the literature. So I think this is another reason why it makes Alloy special, because you're having access to these like real specialists and we're always learning and we're always helping each other. So, there's a whole other group of doctors that maybe you don't always see on Instagram that are working with Alloy, and patients are having access to it. And so we all collaborate and it's really wonderful. So that's what I'm jumping on next.
Thank you. Thank you. All right, you go do that. Thank you to everyone who was here. Thank you, Dr. Menn, again. We'll talk soon. Take care, everybody. Bye.
Bye.